Lifelong aerobic fitness provides powerful protection against cardiovascular disease. Yet a specific, highly trained subset of master athletes harbors clinically silent, potentially fatal coronary lesions. The clinical profile often looks flawless. These athletes display optimal external metrics, including massive stroke volumes and low resting heart rates. Those exact adaptations allow severe underlying pathology to exist completely unnoticed. The primary threats hidden by this physiological remodeling include atherosclerotic coronary artery disease in athletes over 35, anomalous aortic origin of a coronary artery, and hypertrophic cardiomyopathy. The neurobiological, structural, and cognitive adaptations required for elite endurance performance systematically suppress the normal physiological markers of myocardial ischemia. In a sedentary patient, a restricted coronary artery announces itself with obvious chest pain during mild exertion. In veteran competitors, the disease profile presents a much quieter diagnostic challenge. Because the athletic phenotype naturally erases these early warning signs, standard diagnostic tests designed for the general population routinely yield false negatives. For these patients, sudden catastrophic decompensation is often the very first symptom. The masking process begins at the cellular level. When an epicardial stenosis restricts blood flow during heavy exertion, myocardial perfusion drops. The heart tissue immediately shifts into anaerobic glycolysis to meet the energy demand. This metabolic shift causes a rapid accumulation of chemical byproducts in the interstitial space, specifically adenosine, lactate, and bradykinin. Under normal conditions, these molecules act as primary nociceptive triggers. Adenosine and lactate bind to cardiac sympathetic afferent endings, initiating a sharp pain signal that travels up the spinal cord. Despite this intense chemical trigger firing at the tissue level, the classic crushing retrosternal chest pain usually fails to register in the conscious mind of a trained athlete. Endurance training induces a state of exercise-induced hypoalgesia. The nervous system recruits endocannabinoid receptors and descending inhibitory pathways to establish a chronically elevated pain threshold. This biological dampening is paired with intense psychological conditioning. Elite athletes are trained to use top-down cognitive reappraisal, reframing visceral discomfort as standard training strain rather than a threat. This specific combination of pain tolerance and cognitive reframing is highly specialized, appearing far more pronounced in endurance athletes than in those who compete in strength or team sports. Chronic training strengthens the functional connectivity in descending modulatory networks, allowing the athlete to interpret a fatal ischemic warning as ordinary muscular fatigue. This bypasses the body's natural alarm system and causes deadly delays in seeking diagnosis. Beyond the nervous system, endurance training physically reshapes the architecture of the heart. The growth of the coronary collateral network provides a secondary layer of masking. The process at work here is arteriogenesis, which is biologically distinct from angiogenesis. Instead of sprouting new capillary beds, fluid shear stress forces tiny, pre-existing arterio-arteriolar connections to remodel into mature conducting arteries. The repeated extreme elevation of cardiac output during distance running or cycling provides the exact mechanical shear stress required to drive this structural growth. But these vessels have a strict biomechanical limit. Even in the most highly adapted hearts, mature collaterals can only deliver 25 to 40% of normal antegrade blood flow. This creates a dangerous trap. The athlete can function entirely symptom-free at rest and during moderate exertion. However, the moment they push to maximal heart rates, the collateral supply fails to meet demand, leading to abrupt ischemic decompensation. This dynamic also explains a phenomenon known as warm-up angina, driven by the recruitment of collateral conductance and cellular ischemic preconditioning. An athlete might feel an initial tightness in their chest during the first mile. As exercise continues and the collaterals dilate, the pain dissipates. This physical relief reinforces the athlete's assumption that the symptom was harmless. Arteriogenesis successfully protects the heart from infarction while at rest, but in a clinical setting, it actively obscures the presence of severe multivessel disease until the exact moment the athlete hits their physiological ceiling. Imaging studies over the last 2 decades revealed a counterintuitive finding. Lifelong male endurance athletes consistently present with higher coronary artery calcium scores than less active control groups. The difference lies in the morphology. Sedentary individuals harbor vulnerable, non-calcified plaque. In lifelong athletes, the plaque burden is densely calcified. This extensive calcification is the radiographic signature of highly stable, healed atherosclerosis, not an active, vulnerable state prone to sudden rupture. Importantly, these calcium score findings are derived heavily from male cohorts. They cannot be blindly extrapolated to female athletes. Recent studies tracking master female endurance cohorts demonstrate no association whatsoever between lifelong exercise volume and the progression of coronary artery calcium. When female athletes do present with ischemic symptoms, they are disproportionately affected by microvascular dysfunction and coronary vasospasm, conditions that leave the epicardial arteries entirely clear of calcification. Exercise volume cannot reverse decades of cumulative apolipoprotein B and lipoprotein A exposure. Even at high intensities, training does not completely eliminate the infiltration of these particles into the arterial wall. Fitness determines how stable your plaque is, but it does not erase genetic lipid exposure. A complete absence of conventional risk factors does not guarantee an absence of clinically significant atherosclerosis. Because the athlete's heart masks disease so effectively, conventional exercise ECG stress testing performs incredibly poorly in this population. High resting vagal tone in structural left ventricular hypertrophy routinely generate false positive ST segment changes on the readout, sending clinicians down the wrong path. Conversely, the superior cardiac efficiency and extensive collateral networks we just examined easily mask true disease, generating dangerous false negatives. The protocol itself is flawed. Standard tests terminate when the patient reaches 85% of their age-predicted maximum heart rate. For a highly trained athlete, this submaximal threshold stops the test long before their true ischemic threshold is ever reached. Diagnostic protocols are shifting away from submaximal effort tests. Coronary CT angiography is now the gold standard for identifying precise plaque morphology and diagnosing anatomical anomalies, like an anomalous aortic origin. For structural concerns, stress cardiac magnetic resonance imaging with late gadolinium enhancement allows clinicians to definitively distinguish between a healthy physiological athlete's heart and pathological hypertrophic cardiomyopathy. Relying on symptoms and submaximal ECGs to clear a master athlete is a gamble. Verifying the true physiological safety of the athlete's heart requires advanced anatomic and functional imaging. Clinicians evaluating endurance athletes must completely recalibrate their definition of warning signs. Standard chest pain is rare. Instead, any unexplained decline in athletic performance, exertional dyspnea, atypical jaw or interscapular discomfort during intervals, or presyncope must trigger immediate, comprehensive investigation. Modern screening guidelines utilize a tiered framework. Any master athlete presenting with these atypical symptoms or who carries a high pre-test probability of disease is escalated immediately to advanced imaging. When pathology is found, the latest guidelines from the American Heart Association and the American College of Cardiology move decisively away from blanket disqualification. Following revascularization for stable disease, an athlete can safely return to high-intensity training, provided they complete structured rehabilitation, optimize their ApoB levels, and demonstrate a preserved ejection fraction without ischemia on an advanced scan. The modern sports cardiologist does not act as a unilateral gatekeeper. By utilizing rigorous mechanistic data and advanced imaging, the goal is to accurately quantify the risk and empower the athlete through transparent, shared decision-making.